Okay, so we're going to get started. This is the Society of Thoracic Surgeons Adult Cardiac Surgery Database Quality Improvement Series. We're focusing on decreasing vent times. We have a Novant Health presentation today provided by Nancy Honeycutt, who is one of our data core group data managers. Today is June 21st. First up, on the line with me, like I said, we have Nancy, Melinda, and Leanne, and we have just over 260 attendees. So thank you for joining. Nancy is a data manager extraordinaire, STS Adult Cardiac Core Group member. She is a nurse at Novant Health Presbyterian Medical Center in the Heart and Vascular Institute in Charlotte, North Carolina, which I'm sure is beautiful this time of year. Important dates for adult cardiac. I went with the purple theme today because Nancy's slides are this cool purple, so I wanted to match. Today we have our quality improvement series. There are no webinars on June 29th or July 5th. July 19th, we are going to have Diana Alejo from Hopkins come back and visit us regarding the dashboards that she developed at Hopkins for the reducing vent times, tracking vent times and things like that. August 2nd, we have a monthly adult cardiac webinar at 2 p.m. Central Time. August 16th right now is a planned quality improvement series. It is open. I will be reaching out. If anybody wants to come and present any quality improvement projects that they have done, share any best tips or tricks regarding reducing vent times or improving extubation in the OR or early extubation rates, please reach out to me. I may also be reaching out to the SCA, which is Society for Cardiovascular Anesthesiologists, I believe is cardiac anesthesiologist. We work closely with the SCA on the anesthesia portion. And as we know, that's a big part of the ventilation, reducing ventilation time. So if I don't get any takers for August 16th in the next week or so, I'll probably be reaching out to my friends at SCA to see if they'll come and talk to us about working with your anesthesiologists on reducing vent times and improving early extubation rates. August 18th is Harvest 3 close. That will include OR dates through June 30th, 2023. It is a star rating period. Please continue to get your data in and cleaned up as soon as possible prior to that. And then opt out for Harvest 3 ends on August 22nd. So those are my dates that I have right now. Please don't forget to put your questions in the Q&A if you have any. And there's Hankster for anybody who's looking. Did I just close that out? There it is. Harvest 2 is back at IQVIA. We have completed the analysis on that. The release date for that is mid-July. And hopefully we'll be ahead of schedule with that. So coming soon for Harvest 2. It'll be available prior to Harvest 3 closing. And now I am going to hand it over to Nancy Honeycutt. Nancy, I'll let you take it from here. Thank you so much for joining, and I am looking forward. I went through your slides. I'm looking forward to your presentation. So thank you.
Thank you. I'm very happy to present today our latest ventilation time project. We've been through several. This is our latest iteration of this. You can go to the next slide. So just a little background on our program. Presbyterian Medical Center is part of Novant Health. Novant Health is a integrated network of clinics, outpatient centers, and 15 hospitals. We're headquartered in Winston-Salem, North Carolina. Presbyterian Medical Center is a 662-bed hospital located in Charlotte. Charlotte, for those of you who aren't aware of us, we are in the southern part of the state, just above the South Carolina line. And we are at Presbyterian, one of 3 hospitals in our network that perform cardiac surgery and also TVT procedures. So we have 3 cardiac surgeons, 3 full-time cardiac surgeons. That's up just this past year from 2.5. We had a part-time surgeon. 6 advanced practice providers. We work out of 3 ORs. We have a 6-bed CV ICU with ECMO capability. And our program is on the smaller side. We perform around 420 cases a year, CABG, valve, and aortic surgeries, and around 188 TVT procedures. And then you can see the breakdown there, around 70% CABG. And then 33% of our cases are transfers from our community hospitals. Those hospitals serve mainly rural counties in southern North Carolina. You can go to the next. So as I kind of mentioned, we've worked on ventilation times in the past with modest success, I would say. Some of the things we've done, we have developed our own CV ICU specific ventilation weaning protocol. Also, in the past, we've tried to optimize respiratory status. We've tried to establish a baseline respiratory status by obtaining preoperative blood gases and PFTs, and then optimizing those patients as needed. We consult pulmonary as needed as well. We've also posted bedside reminders for staff, including OR exit time and goal extubation time, just as a reminder to keep our nurses and respiratory therapists on track. This is an example or a copy of our vent weaning protocol. This one was developed specifically for our CVRU, CVICU. We had been following the ICU vent weaning protocol, which didn't really meet the needs of our patients. So we came up with our own, and it was formulated with the help of our anesthesiologist, and our surgeons had input as well, along with nursing and respiratory therapy. Next slide. So this is our data. This is progress to date beginning in 2018. In 2018, we decided that we needed to look at our getting our patients extubated a little earlier. Our prolonged ventilation times were greater than the STS rate. And then there was just a lot of, I guess you would call it low-hanging fruit. We were like, most of our patients were getting extubated around the 15-hour mark, and there were quite a few that, we were just barely making it for prolonged ventilation around, 22 or 23 hours. So those things I just mentioned were put into place. We updated the ventilation protocol and really started working on getting our patients extubated in 6 hours or less. You can see around 2021, our vent times actually got worse. Our prolonged ventilation time increased and our early extubation time decreased. So it was around last summer that we really decided to hit this pretty hard and get our patients extubated in a more timely manner. Next slide. So this is what we did. Our first steps included bringing together a work group. This work group was multidisciplinary. Our anesthesia partners participated, our anesthesia APPs, surgery, advanced practice providers, respiratory and nursing leadership participate in this work group. as well as the CVICU nurses and the STS data manager. We established a meeting schedule. We meet monthly. We discuss what's working, what's not working. We review our data and then come up with a plan. We initially set a goal of greater than 65% of patients extubated in 6 hours or less. And in this early stage, we created a bedside tracking tool. Number one, to keep focus, and then also to identify any barriers to extubation. Next slide. This is our vent time tracking tool. And you can see we keep track of all the timing, OR exit time, time reversals are given, time our sedatives are turned off. And then whether the patients met the extubation criteria that was set forth on our weaning protocol, whether they met that before or at 6 hours. And then also phone call time, the time respiratory was called and their response time. We wanted to just see if there were any flaws or holes in our process that was preventing early extubation. Then down at the bottom, we asked nursing to keep track of reasons for any failed weaning. And they would write that in for us. The nurse manager of CVICU kept up with this tracking for us and presents that at our monthly work group meeting. Next slide. So what we found after tracking our patients, we found that we had lost our focus, and this was key. When we first began tracking, we noticed that our vent times immediately improved somewhat, and this was due to the fact that we were paying more attention. So I think that was important to realize that getting your patients extubated in a timely manner takes a lot of effort and a lot of focus and a lot of attention. We also noticed that we had a huge knowledge deficit around our goals and around our weaning protocol. We have had since 2021 almost complete turnover in our nursing staff and our respiratory therapy staff. There is currently one nurse in our CVICU that has been with us longer than 2 years. So we found out that a lot of our respiratory therapists weren't even aware of our specific vent weaning protocol. So we made note of that and did some education around that. We also noticed that patients were coming out of surgery, not too sedated per se, but too sedated to meet criteria for early weaning. Then we also discovered that our post-operative pain management was inconsistent and sometimes inadequate. And that was also a barrier to our early extubation efforts. Patients also were not reaching normothermia in a timely manner. And then, as expected, but also minimal, patients with unstable hemodynamics, bleeding, and acidosis. That affects your early extubation greatly. But we found that the number of patients that experienced those events were minimal compared to the other items that we discovered. Next slide. So what we did, so we provided immediate education to our staff members. We educated on our goals, for early extubation, and we also educated on our weaning protocol. It was important to standardize that so that we could figure out if there was something actually embedded in our process that was preventing this, or just the fact that we weren't following the weaning protocol. We reminded staff about warming measures and made all of that equipment readily available. Our anesthesia partners worked really, really hard on this project, and we couldn't have done it without them. They updated their anesthesia plan to allow for the timely weaning, and they instituted the use of regional blocks. This was big for us. We had not done this in the past. This helped with our weaning of sedation and pain management in the immediate postoperative period. We also reinstituted the reversal of paralytics prior to arrival in the CVICU, which is something we had done in the past, but again, it kind of fell off the radar. And so we started reversing the patients prior to arriving in CVRU. We also added some non-narcotic pain management options for our patients intraoperatively and postoperatively. And we standardized the way we weaned sedation postoperatively. Next slide. So you can see around the end of September, early October, our early extubation numbers started to rise. We were up from around 47% extubated in 6 hours or less. By November, we were around 60%, which was an improvement. And then our mean vent hours decreased. You can see back there in May of 22, we had a mean vent time of 29 hours. I'm not sure what happened there, but I'm sure it was probably some outliers. And then you can see that decreased, trended down from July to November. Our
Can I
mean
just,
vent hours.
I have a questions on all
Yes.
of your slides, Nancy.
Yes.
When did you start on this slide? When did you start the project? I forgot what date you had said.
Oh, I'm sorry. We started last summer around mid-June.
Okay, so right around this time.
Mm-hmm.
Okay.
Yeah,
All
and
right,
you can tell in June where we were focusing our
Yeah.
efforts on vent time. We immediately saw some improvement there.
That's pretty cool. Okay, sorry, I'll be quiet because I have lots of questions for you.
Oh, no, that's okay.
Okay.
You can go on to the next slide. Okay, and then here, this one is our prolonged vent times, prolonged ventilation decreased. You can see from July to August, we dipped down to around 5%. Dipped back up, but in November, we were back around 5% of our patients with a vent time of longer than 24 hours. Next slide. So what we found from this first round or first cycle of improvements, we found that our interventions helped, but we still weren't quite meeting our goal of getting 65% of our patients extubated in 6 hours or less. So at that point, our surgeons and our anesthesiologists collaborated and proposed that we begin extubating our patients in the OR. This was a big discussion, and they decided that from the get-go, it would be collaborative and it would be conservative. There's a discussion that takes place between the surgeon at the beginning and at the end of the case. And also, I forgot to mention prior to that, when the surgeons are evaluating their patients for surgery, and they always go see the anesthesiologist the week before their procedure. So this is a discussion preoperatively at that point, but also at the beginning and the end of the case, in case anything has changed from the pre-op period. And also, our anesthesiologists agreed to start rounding on our patients in CVICU. This is something that had not happened in the past. So we made these changes around mid-December, I believe. So here are some exclusions for operating room extubation. It is an intentioned discussion. It's very intentional, and we're very conservative. We do not extubate any circulatory arrest cases, any multi-valve cases, and most of our aorta cases remain intubated. There are a few that come through that are very much elective. Those may get extubated in the OR, but that's again a discussion amongst the surgeons and the anesthesiologist. We do not extubate if there is a mechanical assist device in place. We do not extubate patients who have a low ejection fraction, pulmonary hypertension, severe pulmonary disease, morbid obesity. And then obviously, if the patient is hemodynamically unstable or bleeding, we're not going to extubate those patients either. Next slide. So again, we started extubating in the OR, and all the while, our patients that weren't getting extubated in the OR were still doing everything else that we had been doing. So in December of 2022, our early extubation rate was around 62%. And then we increased to above 80% from January through May.
Fascinating.
Yeah. Next slide. Our mean ventilation hours went down even more.
Holy macaroni, look at that. You should be so proud, Nancy.
We
Like,
are, we're excited.
Yeah, that's great. Sorry, that's cool. Good job.
We're excited. Just because we're a smaller program, we feel like we have to be extra good. So this has been great progress for us. And then our prolonged ventilation times also trending down. 0 prolonged ventilations in February and in April.
Woo woo.
I don't think that's ever happened for us. We did dip back or rise back up in May. Had quite a few outliers in May. We had a very busy month. Our volume increased significantly in May.
Wow.
Next slide. And then if you're wondering if we had any sequela from extubating our patients in the OR, this first slide here, or the first graphic, shows the percentage of patients extubated in the OR. And then the slide beside of that is our reintubation rate. And that actually went down to around 3%.
Wow.
In March, April, and May. So this tells us that we can extubate our patients early, and that we can extubate them in the ORs, and we can also extubate them in our ORs safely. And just anecdotally, I feel like our patients have been doing so much better. We've had an improvement in our outcomes overall by liberating our patients from the vent in a more timely manner.
Wonderful.
Yeah.
And we're at time for questions or presentations at questions now. I could tell you that this is fascinating, and I loved how you went through. At first, when I saw your data, I'm like, oh, like I don't know that that looks so good. But then as you were going through the slides and explaining it, it's kind of neat to see how this was how it was a longitudinal quality improvement project, and you kept on going back and reevaluating yourselves. And when you noticed something wasn't working, that you went and fixed it. So I thought that that was really neat to be able to see your process laid out that way, and to see what the impact it was once you guys went back and did all of that. And great job on your outcomes for sure. I have questions on all of your slides, just about.
Okay.
um, I know that all made sense, and I'll take questions too, but I'm going to be selfish and I want to ask my question. I want to ask a couple questions first. For your protocol that you have here, is this still the protocol that you're using
It is our
today?
protocol.
Yeah, okay. And would you be willing to share that? And if not, that's okay. Would
Yes,
you be able to check if you could share that with, because I know people will ask for this.
yes.
Okay.
I think it's okay to share it, but I'll just follow up and get back with you
Okay. That
for
sounds
sure.
good.
And I know that protocol looks kind of busy, but we that's a combined order set for 2 hospitals. And so we between the 2 facilities, Presbyterian Medical Center and Forsyth Medical Center, we extubate a tiny bit differently. Forsyth weans based on the blood gas. And we, at Presbyterian, we wean based on a spontaneous breathing trial.
Well, that makes sense why there's so much criteria here then.
Yeah.
Yeah. Okay.
Just to clarify that.
Yeah. Thank you. Okay. I'll take people's questions, and then I don't want to be too selfish. Okay. First one is from Danette, and I could take this one. Can you remind us what the goal of this initiative is regarding the extubation time? So the goal is to reduce the ventilation hours, and we'll do that just at a general reduction of ventilation hours. We should see prolonged ventilation decrease, mean total vent hours decrease, and an increase in early extubation. Early extubation for STS is defined as 6 hours or less than 6 hours. And we reviewed this on the first quality initiative webinar, where we went over the importance of the different timeframes and where those came from. There's lots of good articles out there regarding postoperative outcomes and early ventilation hours for appropriate patients, as well as early ventilation hours for inappropriate patients. So you could do a search on that, but the goal here is to reduce vent time overall. And this question's for you, Nancy. It's from Judy. It says, how do you encourage your nurses to wean the sedation? Do you use Precedex or propofol? What do you use for non-narcotic pain medication?
So as far as weaning goes, we use both propofol and Precedex. And we can wean, or we can extubate with Precedex left on. So our the main thing we're doing is weaning the propofol off. And traditionally we had been, nurses were doing that however they saw fit, but we kind of standardized it to where we would cut it off, or not cut it off, but turn it down to half and give it some time and see how the patient did, and then turn it all the way off. And so we kind of made that part of not our protocol, but our weaning, and we educated on the importance of standardizing that. And the bedside nurses were very receptive to that. As far as the non-narcotic medications, so we also are participating in an initiative around enhanced recovery after surgery. And so part of that protocol is to decrease narcotics, among other things. It has a lot to do with nutrition and optimizing the patient preoperatively. But one of the medications that we give in the OR for our enhanced recovery patients is IV Tylenol. And we've extended that to all of our patients who we are hopeful are going to extubate in the OR or early. And that is IV Tylenol, and they get a dose of 1 gram in the OR. Postoperatively, we also have started giving Toradol, 1 dose of that usually, and then we make sure that the patients aren't having any bleeding issues or platelet issues or anything like that before we give that.
Right. That's really great. And then I want to just touch on that. You said you worked with your nurses on the propofol. Is it propofol where you cut it in half and then
Correct.
shut it off? And the IV Tylenol. It sounds like you had a huge turnover rate. I think usual ICU turnover is, from what I've read, is around 30% or 12%. But it sounds like you had a much larger turnover rate
We're
in your
like,
ICU.
yeah, nearly 100%.
And when you hired new nurses, are they typically experienced, or are they coming to you as new nurses and you're training all of them? I mean, that has to be so difficult. So either way, if they don't have a CVICU experience, they're still new to that environment. And just training them on the basics of that nursing is one thing. But then when you're trying to actually improve the quality of care, it must, can you explain, can you like
Yeah,
talk about any of those challenges? Because I'm sure that
yeah.
that was something. Yeah.
That was very challenging. And I think that the turnover had a lot to do with our actual vent times as well. But so as far as experience, all of our newer nurses have CVICU background, which was a huge plus. And it also helped with our it helps with our quality initiatives because they come from different places and have different ideas.
Yeah, that's true.
So that was it was actually very positive. It was very positive. So, but yes, to answer your question, it's challenging, but it's positive. And I believe all of our newer nurses have cardiac surgery background.
Yeah, that's lucky because
Yeah.
and that's true. If they come from other facilities, they're bringing all of their experience with them on different initiatives that may have happened or different ways to manage quality improvement with them. So that's good. Next question. Oh, go ahead.
This is actually Melinda. I have a question too. Nancy, when you mentioned the use of Toradol,
Mhm.
have you noticed any renal issues with that?
Good question.
So no, we haven't. And it's kind of, I don't know if the right word is, I don't know the right word, but we have had issues with renal failure and AKI in the past. And since we started this ventilation project, all of our outcomes have improved, including our renal failure. So it's kind of strange. But I mentioned bleeding as kind of something we look at when we're thinking about giving Toradol. We also look at renal function. I forgot to mention that. So somebody that has chronic kidney disease would not be getting any Toradol.
I
Oh,
knew you
great.
intended to say it. That's the first thing we
Did.
say when we talk about Toradol is kidneys.
Yes.
Yeah. And you also saw you said it had a positive impact on your outcomes. And have you also seen a decreased length of stay at all?
We have seen a decrease in our post-operative length of stay by about 1 day.
Wow.
And And I don't know, I honestly don't know how some of this is related, but our atrial fib rates have gone down. I think just overall, our patients have done better, had less bleeding. I don't know.
It's something to look into if you're seeing all of that. I mean, having somebody mechanically ventilated is a big deal on our bodies. That's why it's so important to get it off as soon as the patient's able. And there's tons of research out there about all of the impacts of ventilation. But it'd be interesting to look more closely into that AFib one and early, and just to see like all the correlations, because if you're seeing that at your hospital, it's probably something. It probably isn't a fluke. I mean, or
Yeah.
Well, one thing else I want to bring up, because you did mention you were also providing something about nutrition. I don't remember what you said, but are there things that you're doing to supplement these people's nutritional status?
Yeah, so that is actually part of our Enhanced Recovery After Surgery project, ERAS, we call it.
yeah.
And so those patients, they're mostly elective patients. We're trying to make this work for our inpatients as well, but these are mostly elective cases. And so preoperatively, we optimize their nutrition. We treat their anemia. Those patients that have lower hemoglobins go to our infusion center and get IV iron. Pre-op, we also have involved, prior to COVID, our cardiac rehab team, they were doing prehab for our patients. So getting them, on an exercise program and getting them a little more fit prior to their procedure. But nutrition wise, and also we don't keep them NPO prior to surgery as long. We give them, they get a nutritional shake, I believe 12 hours before their procedure.
I was just wondering how those group of patients, because there's a ton of literature about nutrition out there and overall status. So
Right.
I didn't know if you had looked at those patients separately or they're just all in this same group. And I wonder how much that affects your overall results. You're talking about everything's improving.
Yeah, right.
Yeah, and it would be interesting to track your albumin too, right? Like, yeah. I have you been doing that?
No. Well, I can't say no. So our advanced practice provider for anesthesia, Vicki, she is the leader of this project, and she collects a lot of data on her own around her project. I kind of work with her a little, and we have looked at our ERAS patients separately, but for this particular project, all of our data is combined. So it would be interesting to see the difference between the enhanced recovery patients and then everyone else. That's a good point. And we definitely are looking at those patients, but looking at them separately as it relates to the ventilation times is something we could look at going forward.
Yeah, that might be something. Okay. Are you good, Melinda? Can I ask a question then?
Yeah, I was just real interested in that when she mentioned that. So thank you, Nancy.
I mean, nutrition is so important, and I think that we don't typically think about it. And traditionally with surgery, any kind of surgery, you traditionally keep the patient NPO, and then you don't feed them after surgery for quite a while. So, I think it's hugely important. And I definitely can see how it would impact their care.
Yeah. I would probably have ICU delirium just from being NPO for so long.
Me too.
So
Me too.
I'd be angry. I would be the angry person in the ICU. Can you, oh, and quite a few requests for the protocol and the CVICU worksheet. So if you're able to share those, I'm happy to post them in PDF format with the slides.
Okay, I will get back to you today.
Okay, yeah, no problem, no rush. When you said your anesthesiologist agreed to do rounds in the CVICU, did you mean before surgery for inpatients only, since elective cases wouldn't be in the CVICU before surgery? Or did you mean anesthesiologist starting rounds after surgery only?
So the rounding, anesthesiology rounding is post-op for the patients that are extubated in the OR, and they'll actually look at the other patients as well. But so our patients go to they go to see the surgeon pre-op in their office, and then they also come over to the hospital and see the anesthesiologist for that visit.
Mhm.
And that's where we get their PFTs and ABGs as well. So there's an anesthesia visit prior to surgery for our elective cases. And then I believe the inpatients do meet anesthesia before their procedure in the hospital for the inpatients. But the rounding I was speaking about was post-operatively in the CVICU.
Thank you. Did this project measure how it improved opioid? I could never say that word. It's probably good. I don't know how to say it. I can never get it out. Opioid use.
Yes, we've had a decrease in opioid use, and I don't have that data today. Our anesthesia APP keeps track of all of that, so I can get the exact numbers, but we have had a decrease in opioid use.
That's wonderful. Yeah, Hannah has a question, and my question goes sort of right along this line too. Hannah's question is, do you identify pre-qualified patients for early extubation pre-operatively? So are you able to identify patients who would be able to be extubated either intra-op or early extubation less than 6 hours post-op? Do you identify those patients before going into surgery?
Yes, we do. Those
And then
patients. Mhm.
my question on that is, do you educate the patients? Do you educate the patients pre-operatively regarding extubation, like what to expect and things like that?
Yes, that is discussed at their pre-surgical anesthesia visit.
Very
And
good.
also with the surgeon during their consult.
Yeah. But so they know when somebody's leaning over, I'm saying, okay, I'm going to pull this big tube out of your mouth, that they know that
Yes.
that's going to happen. And they're a lot like, what the heck is this? And who are you? I've never seen you before in my life.
They discuss awake extubation.
Good. And this is a good question from Jenny Anderson. Jenny's asking if you are using the STS online risk calculator routinely on all patients, and is there a correlation between the STS online predicted risk of mortality and prolonged ventilation to this project?
We do use the risk calculator routinely for our patients, but I haven't looked at that. So that would be something that I would also be interested to know. And
Yeah, there you go, Jenny. There you go, Nancy. More work.
More work.
Yeah, good idea, Jenny. How do you operationalize and I've seen quite a few questions coming through on the nutritional side that you had just presented. I don't know if there's any type of protocol or anything you could share or would be able to share regarding the preoperative optimization of nutrition for patients before going into CV surgery. But if you have anything like that you're able to share, Nancy, we would love to also pass that along. I don't know if you have like a protocol or a list of goals, things like that. this is Rochelle's question. She says, how do you operationalize the pre-surgery nutritional drink? We are in the beginning stages of doing this, trying to see what would work best on our elective cases with doing this.
I don't have a good answer for that. I will have to get back to you on that. Perhaps on a later quality call, we may even be able to get some of our folks that are working on the enhanced recovery project to come speak.
Yeah, that would be great. I would love that
Yeah.
for the ERS project. Yeah,
Yeah,
absolutely.
and I'm sorry, I don't have an answer about the nutrition piece of that,
It's okay.
but I can probably get our protocols and such.
Okay. Yeah, if you're able to share them, if not, certainly understand. Does this data include all patients or elective cases only?
This is the data I presented today is cabbage only, and it includes all cabbage cases, elective
Wow.
and otherwise. We do this project for all of our patients, however. So we do have data on all the patients. I didn't put that into the presentation, but the results are very similar. But it is elective, urgent, and emergent. Now, our emergent cases obviously aren't going to be extubated in the OR, but they're included in the data.
Good to know. Thank you. It makes it more impressive. Deborah saying we did ERAS for NISQUIP and we gave the drink to the patient in the office at a pre-op visit with instructions. Thank you, Deborah. And then I see Hannah's. And then Mary is providing some more ERAS instructions saying that they meet with the open heart navigator preoperatively, who sends them with a bag full of goodies, instructions, information, and the drinks as to when to drink the drinks. And then I see Hannah, I see your hand raised. I'll unmute you. I don't know if you still wanted to chat or not, but you could go ahead and unmute yourself.
Hi, I was trying to let you know that we're doing some research with specifically about reversal agents impact on cardiovascular patients.
I'm sorry, could you say that again, Hannah? Oh, I think
Got too much feedback. Can you hear me?
I can hear you. Yeah.
Oh, good. We're doing actively now some research on early extubation using reversal agents. And we just had our first article to prepare for this research published. And I sent you the name of that article. And we're now doing a blinded study of cardiovascular patients that are pre-identified for our early extubation protocol, which we've had in place for quite a few years. And those patients would be enrolled in the study, and it's blinded. So the people who are reversing them don't know if they're giving a reversal or not.
Oh, yeah, I'd love to, if your research doctors or research physicians are wanting to present that, we'd love to have that info.
Yeah, I'll talk to him next week.
Yeah, thank you so much, Hannah. Okay, the nutritional drink from Cindy Spears, the nutritional drink, hydrating protein, ensure, et cetera. Which one have you used? And ensure, it seems, is what Deborah used. That was for Cindy. Okay. Well, I think we're all done here. No more questions came in. Nancy, that was a really wonderful presentation. I'm certain that I have more questions.
Let me know.
Oh, I know I will. Let me see if there was anything. I'm trying to remember what slide it was. I know it was, what was my question? I already asked that one. And it seems that it was kind of interesting when you were going through these goals with anesthesia, the warming, the pain medication, the weaning of sedation intraoperatively. When you're going through these, it's similar to what we heard happening from Dr. Whitman from Hopkins in our first presentation, also very similar to the presentation we had last week. And there's lots to be said about working in the heart team with anesthesia and how they can help you with these processes at your institution as you're implementing them. I do have a poll question for everybody, so if you're still on, don't hang up yet. My question is, hold on. Let's see if I can find it quickly. I'm gonna have to create one. My question's gonna be is, have you done anything with this information? Are these webinars helping you? Are you actively, are you beginning or continuing a current reduced ventilation? Well, then I'll send it out as a poll question. As a result of these webinars, are they helping you any? Are they giving you ideas? Have you introduced them to anybody at your site? Those are I want to know if this is helping and if it's really, if these are useful to you. Let's see if I can launch this one. Hold on. Okay, here we go. Are you beginning, and I don't know if my spelling's right, or continuing a reduced ventilation project as a result of these? Or if not, are you planning to? I guess would be a good part to that too. I want to make sure that we're reaching out to people. I've heard from, I was on a phone calls with some anesthesiologists. They said that there's buzz going around from the surgeons about working on vent times. They're thinking it's coming from, from this initiative. And we really want to make sure that the information is getting shared across your team. And if there's any way we can help share that information to the heart team or any type of supplemental information, even any type of marketing material you think would be helpful for us STS to push out to help you with any initiatives you're beginning or have ongoing at your site, we would love to help you. So it looks like approximately 70% of those 73 out of 107 who responded are actively or beginning reduced ventilation project, which is wonderful. I can't wait to see the results of this when we keep on looking at the national data, and 30% are not. I hope the 30% or 34 sites have the ability to do that. And if you don't, if you need help with anything, we're here and we have a great resource, a great networking group with everybody on these calls to help us with that. Danette saying we have introduced this initiative to our CV leadership, has not been taken on as an official project. We could use marketing to help get them on board. And I have sent an email out to the STS marketing team to hopefully help us get more information out both to our surgeons and to our anesthesiologist associate members for the STS. So, all right. Well, thanks again, Nancy. Great job as always. I look forward to seeing continued success with your project. Very proud that you were able to do this, and thank you for taking good care of our CV surgery patients by helping with this. A great presentation. Thank you for sharing this information. Those enhanced recovery, is it for all surgery or just CV surgery? I think it's for all surgery. And then Michelle said her no to the question was relating to a working protocol. So if it's not working, that's okay, but at least you're trying, because that's all part of quality improvement and process improvement, as we have to continue to try. And then we find a way to make it work. So thank you. Thanks, Michelle. All right. Thanks, everybody. Thank you, Nancy, again so much. Really appreciate it. I hope everybody has a great rest of the day and take care